and the balloon is up, we're trying to open up the artery, and then this is the finished product of what happens to this guy. He gets a stent, the lesion gets opened up, and then these individuals usually stays with us for 2 to 3 days in the hospital before they go home. Now, the problem with them going home any sooner is sort of a hangover from the olden days when stents were not available. These mechanical complications tend to happen 3 to 4 days, and so we tend to keep them. But there is a move for us to send these individuals back out of the hospital as soon as possible, since they haven't had any transmural infection. We've been able to interrupt the process. So this is one pathophysiology and one way that clinical coronary artery disease is treated. Now, the second form is non-ST elevation of MI. This is another form of myocardial infarction. Now, this is also, remember, due to plaque rupture. However, the difference between this and the other one is, even though platelets comes in here, even though a plaque gets ruptured, the occlusion is incomplete. So the vessel is not totally occluded, and so there is some amount of effusion. So these people will, yes, they'll have some chest pain, but the chest pain will go away when you treat them. Now, the diagnosis here, notice, is made not just by EKGs, but we depend heavily on cardiac biomarkers here. In fact, EKGs tends to be a little bit underwhelming in these individuals. They can present to you their EKGs pristine, and you check their biomarkers, and the next biomarkers is off the roof. So here in non-ST elevation MI, where the vessels are not occluded, we tend to depend a lot on biomarker. But yes, we do EKGs, and sometimes it helps you see what's going on. Now, this condition is not emergent because, remember, the vessel is not completely occluded, right? In the United States, we say that the person needs to get into the cath lab in 48 hours. In this scenario, lytics have no role at all. In fact, it is contraindicated to give anybody thrombolytics because the vessel is not fully occluded. This person needs to go to the cath lab, and there's no role for lytics in this case. So usually what happens in these individuals, even if they show up on Fridays, we keep them till Monday morning before they go to the cath lab, and then we go and define their coronary anatomies. And then based on that, we decide on which best form of revascularization to do, whether or not we choose stents or whether or not they are candidates for bypass surgery will be determined by the anatomy that we see in the cath lab. And let's look at this lady. She's 65, has hypertension, diabetes, also had left-sided chest pain. Same story, right? They will take some antacid because they think they're having indigestion, and then it doesn't go away, and then they call 911. Then the emergency room, the EMS also does the same thing. They do for everything. They do an EKG to make sure that there is no ST elevation MI, and if not, then they have all kinds of time in the world to transport the individual to the nearest emergency room for them to be treated over there. This is the troponin. Now, we were using CKs and CKMBs, and as you know, they tend to be much, MB in particular, tends to be very specific, but it's not very sensitive. Okay? We've gone through a series of troponin. We started with troponin T's, troponin I's, troponin C's. So we have very, very sensitive ones of detecting even the slightest damage to the myocardium. What is costing us is that because of its high sensitivity, we tend to send individuals unnecessarily to the cath lab. Because even if you tear a slight cardiac muscle, there will be an elevated troponins. And a lot of doctors are afraid of seeing just troponin go up. And so that gives us a lot of business, but that hurts the state because a lot of people call us to see this. But this individual's troponin initially was 1.2, it went up 23, and then it came down. She stayed in the hospital. It was a Friday case, so she went on the Monday. As I said, you can see this well, but even this is better. I mean, this you can see some STT changes here, depressions in the lateral leads, and some of the depressions in the inferior leads. But most of the time, people who show up with NSTEMIs are pristine EKGs. Maybe you see LVH on it. This doesn't help you that much unless the patient is having active chest pain. So these individuals got aspirin, he got loaded with Plavix, he was on heparin during that time, her pain went away, she went to the cath lab non-emergently, and then we went to define her coronaries. I just chose a few shots here. Here the guide wire is in already. We're advancing the balloon, but you can see that sorry. Just distal to that is that long thing down, the vessel down there. This is the left main, the branches of the left main, the circuit, and then the LED going down, and you can see right in there. That's where the lesion was. Now this was fixable, so this individual got this fixed in the CAD lab, and this probably will be the final result where it's fixed. These, on contrary to STEMIs, can go home the same day, actually, or they stay overnight and go home. So these are not kept in the hospital for a long time at all. They go home, but both the STEMIs and NSTEMIs go home on the same regimen. They go home on aspirin, they go home on Plavix, we call them dual antiplatelet therapy. All these individuals have statins, and then their blood pressures are treated with beta blockers and ACE inhibitors if they tolerate. Now the next form 2 are those that are due to, not necessarily due to plaque rupture, but they are due to slow and progressive narrowing of the vessels. Now the first one is angina, as I said, is due to progressive narrowing of the coronaries, and so you can think about it as a coronary insufficiency situation instead of a plaque rupture. Most occurs with exertion. The diagnosis is mostly made by symptoms and history. A lot of the time, nothing helps you. They haven't killed muscle yet, so biomarkers are usually negative. Their EKGs are best because they are at rest when they are sitting in front of you. You might see maybe LVH if they've been hypertensive for a while, but you might not see anything. So there's a lot of clinical acumen here in trying to define what's going on in these patients. EKG may or may not help, as I said, and biomarkers are almost always negative. There are two kinds, stable and unstable, and I'm not going to talk about that because I just had 20 minutes, but we will look at a case and see how this was treated. It's a 73-year-old male, long-standing diabetes, hypertension, hyperlipidemia, and smoker. 3 months of chest pain, exertion, and shortness of breath. He could walk 1 feet without symptoms. Presented to his PCP, who was referred to me for further evaluation. This guy's EKG. All that you can pick from here is that this guy has been hypertensive for a while. He has LVH, and this is, if you look at these, if you look at the S wave here and the R wave here, it's more than 35. And so by Sokolov criteria, this person has LVH. And so that's all that it helps you. Now the way we treat these people is quite different. We tend to risk stratify them, and I'm sure you guys do it also here. We tend to put them in 3 bins. Are these individuals low, intermediate, or high risk for coronary artery disease, since we don't know them to have had coronary disease? And age weighs a lot in these clinical decision making. Remember that initially I said age contributes more than 50% of the prediction model if you want to know whether somebody has coronary artery disease or not. So if a 35-year-old woman comes to me with chest pain, at the back of my mind, he has to have a very good story. Otherwise, this is a low prop, and anything I do to this person, I'm asking for a false positive test, and so I better leave that person alone. However, a high-risk individual needs to go to the CAD lab. So once we risk stratify them, the low risk, as I said, I send them back to your doctors. These people probably can have anything. If I do a stress test on these individuals, I'm asking for a false positive, and that will push me to have this individual, so I'm not going that way. You can treat with something else. If they are intermediate, we do stress testing, and you guys do it here. And if it's positive, they proceed to the CAD lab. If they are high risk, they go straight to the CAD lab and see if they came in. And so this is an elective procedure. They will come in on a day to get a cardiac catheterization, and then we'll see what they have and treat them based on that. If they are intermediate risk, that is when they undergo stress testing, and I'm sure you guys do them here already. My hospital is heavily on cardiac MRI and echocardiography. Our gamma camera is owned by radiology, so we barely use them, even though where I trained, we were heavily gamma camera users. We do stress testing. So you do these tests on intermediate individuals, and if it's positive, then yes, you go ahead and CAD them. If it's negative, you send them back to their physicians that they do not have any disease. Now the management is medicine, medicine, medicine. As I said, These are the options for revascularization if they need revascularization, and the anatomy dictates what form of revascularization they're going to have. But the medicines are usually aspirin, antiplatelets. You vasodilate them and give them a nose, and if you're pushed to the wall, and you can't do anything about it. Now the last clinical syndrome is ischemic cardiomyopathy, and this is a big problem because it tends to be quiet, and by the time you show them, they show up, they are very, very late. Most of these individuals have had blockages for years because it was a slowly progressive thing. It wasn't painful, and so the heart muscle is weak already. They show up with pedal edema, they are in florid pulmonary edema when they show up. As I said, they present with heart failure. Now, these individuals are treated first for the heart failure first. We forget about whatever caused their heart muscle to be weak. We diurese them till we get them dry, and then we ask ourselves what caused this. And there are various modalities and management pathways for this syndrome or this disease, and I'm going to talk about one pathway, and if you have questions I can tell you about the other pathways.
Go ahead and talk about the other pathways.
So, it's a 72-year-old male who has never seen a doctor before. He presented to the emergency room with worsening shortness of breath, apnea, dyspnea. This is all explaining that the person is in heart failure. Now, he was admitted to the hospital as a case of acute decompensated heart failure, and so he was admitted and diuresed. So we usually hang lasers on these individuals and dry them out. But once you dry them out, you come out to, well, what caused their heart failure? Now, this is the EKG for this individual. Off the bat, you will know that this person has probably had a heart attack before, right? You see all the chest leads are all down. This person probably has had a large anterior wall MI at home. He probably didn't know that he had it, and so now he's paying for not knowing that he had it. Now, this is this person's heart. Now, this is a cardiac MRI. It's similar to echocardiography. You see the same, even though you have better resolutions here than you do for echocardiogram. And I'll also show you, even though you can do with echocardiogram, how MRI probably is superior, even though it costs more. Now, you can see that this person's heart, this first one, is a two-chamber view. This is the left atrium, the left ventricle. This is a three-chamber view. You see part of the right ventricle there. This is the left ventricle, the left atrium, and the aorta here. This is a four-chamber view. There's some amount of MR here, the right and the left, and these are the short axes. You could see that the walls are not moving that much. Now, sometimes you get a clue from here. Sometimes you get a clue from here that the walls are so thin and bright. Now, the walls are so thin and bright, you know that this muscle is dead, actually. And probably this person will not need revascularization. Now, remember I told you they come in with heart failure, and so you diurese them. But guess what? By the time you finish, they already have some kidney problems going on. So going to the cath lab is a big decision here. Do you go and give them a wab of contrast to push them over the edge onto dialysis, or do you try to investigate to see whether they need that? Because if all these muscles are dead, you have no business taking them to the cath lab. You can just treat them with medicines. So, this is this person's CAD. This guy went to the CAD lab. This is his CAD. Now, this is also the left main at the sec, and the LAD. You can see lesions here and there. And then if you go on to the next one, the right side is also fluid. Now, there is a dilemma here. The dilemma, as I said, is yes, he has three vessel disease, but does this individual need revascularization? As I said, before you can do the revascularization, this guy got contrast everywhere, right? But before you do this, you try to determine whether or not those muscles are viable. Okay, so you go through studies for viability. There are different ways of determining that. And in my hospital, we tend to prefer one to the other. But let's talk about the concept of myocardial viability. Now, we know that the cardiac muscle can exist in all these states. It can be hypercontractile, it can have normal contractility, it can be hypokinesis, that is, it's not moving, but it